Welcome again to a promise renewed for Kalusugang Pangkalahatan, a stakeholders forum on enhancing capacities to save mothers and children. I'm Veronica Baluyot Jimenez, and I will be your moderator for this morning.
In the KMC position. No? The only thing that I want to add is that there was this misconception that KMC is just for those who do not have an incubator. So in one of the articles in Lancet, they said that this may be one of the reasons why KMC implementation was somehow not fast-tracked, because the developed countries before thought that this is just like a means to alleviate the lack of incubators. But now even developed countries, even in the presence of incubators, they're actually doing KMC. Not only because of the advantage of thermal care, but also for the other advantages of KMC, which is faster weight gain, which will translate to faster earlier discharge at home, to the parents, and other advantages which were found, like improvement in maternal bonding. And what we found in the several studies here in the Philippines would be, number one, thermal care, faster weight gain, and we found a shorter duration for oxygen requirement and shorter duration for the pressurized oxygen, which is nasal CPAP, in babies who are in preterm babies, so that the interventions, the oxygen support is significantly shorter if you place the baby on KMC rather than placing the babies on the incubator. So my answer is that it's more than the need for thermoregulation incubator. It has more advantages other than.
Because I remember when I gave birth to my 5 children, they put the baby immediately on my chest soon after birth, right? But how early can you actually implement KMC? And do you need to combine it with the conventional method for low birth weight babies?
Actually, it can be started as soon as the baby is born. A low birth weight who is breathing well at birth and appears to be in no distress can benefit immediately from the kangaroo position. But I'd like to correct the misconception that KMC is just putting on the chest of the mother. KMC entails the 3 components: putting the baby skin to skin, breastfeeding, and breastfeeding support, because we're dealing with low birth weights. They're not expected to be able to breastfeed effectively all the time because of their size or early age of delivery. So breastfeeding support is very, very important in KMC. And then comes the fact that mother and baby needs to adapt to each other before they can even go home. So it's a process, it's a whole concept. It begins with skin to skin, like what you have experienced with your babies, but because we're dealing with low birth weights, it goes beyond the skin to skin position.
And even if it's a cesarean
Definitely, yes.
And is there a need to combine the conventional method and KMC?
Definitely, there are, KMC did, from the start did not say that we will not need incubators. That's not true, because there will be babies who will still require special care. So for those babies who eventually manifest respiratory distress or get sick along the way, we will still need to put them in the conventional way of caring for prematures and low birth weight.
So there's really a study that the KMC was able to reduce morbidity and mortality?
Definitely. I think the posters outside show the local evidence that we have generated. And of course, there's a lot in the literature on the support that there is much more benefit in doing KMC.
Okay, so let's put a face to these studies. I'd like to ask Dr. De La Merced, what were your experiences in implementing the KMC method?
When we were starting in 2000, when we were just starting the program, Fabella is actually attending to 80 to 100 babies per day. So that our monthly sales would range from 2,500 to 3,000 per month. And 7% of that are KFC eligible babies. So that would be 200 to 300 per month. So if you have seen Fabella, the size of the NIC is not even 1/8 of this room. So just imagine the overcrowding, and that would translate to higher chance of dying during their stay. So at that time, when we were attending to 200 low birth weights, actually we started with only 40 to 50% of that number actually being enrolled to KMC. So maraming namamatay even before they are enrolled. But over the years, for the past 5 years or so, we have increased that number from the previous of 40 to 50%. We are now actually enrolling even as high as 8% of our low birth weights, and that already includes even the 1 kilogram babies. So mataas talaga yung inakyat ng survival rate among low birth weights. And not only that, more mothers are more actively involved in the care of the newborn. So instead of asking us, especially when we used to discharge babies at a weight of 1.8 to kilos kasi takot yung mga mommies. So they would even ask, okay na po ba talaga ang baby ko na iuwi? But now, the more common questions would be, Doktor, okay na kami kasi kaya naman namin. So we have discharged babies even with a weight of 1.2 kilos. So they are more active, they are more confident. So that would translate also to shorter hospital stay, less chance of acquiring new infections, and that would also mean lower hospitalization costs. So lahat masaya. Not only the patient, the family, the hospital staff, and even the hospital administration. So I think the next question would be, mahirap bang mag-KMC? When we had the course and implementation last February among 5 government hospitals, the more common concern would be we don't have the budget, we don't have the space, we don't have the extra manpower to look after those babies. Actually, critical to the implementation of the program is a strong support from the administration. Actually, in our hospital, they don't just support the program, they lead in the promotion and the implementation of the program. They ensure that the quality of the implementation in a hospital would remain the highest standard in terms of providing the personnel, the facility, and the supplies. And that when we meet personnel, we are not requiring additional manpower. We're just reorienting the existing staff in terms of how do we provide KMC. And we don't need high-tech facilities. We just need a space, a comfortable chair for the mother, at tube labs. That's all. So hindi po mahal at hindi po mahirap ang KMC.
Can you explain? I just want to visualize it, no? So you put the baby beside the mother for breastfeeding and for the heat and all that. And then there are times that you need to put the baby back in the incubator. Is that how it goes?
It depends. During the initial management, for example, the baby is still on the nasal CPAP, requiring oxygen. So the baby remains at the NICU, but the mother can start providing KMC. So kukunin niya from the incubator or from the bassinet, then she can provide the KMC. Once the baby has stabilized and is ready to be moved in, that's the time we offer 24 hours or continuous KMC. So it can be intermittent if the baby is not that stable yet. If the baby still needs NICU care, then we can start with KMC, but the moment they are roomed in, then that's the time they offer 24 hours or continuous KMC.
Weren't the mothers scared to start, to remove the baby from the incubator because, oh my God, it's so small and,
Yes, once they've been enrolled in the program, so the medical staff, the nurses, the weavers would train, assist the mother, and we regularly assess how well they are adapted to the program. So tinatanong ko sila every day kung anong problema nila, ano ba yung concerns nila about caring for their newborns. So we regularly monitor how well they do with the KNC positioning and the program.
So, Dr. Mendoza, is this only a Philippine thing, or is KNC already being implemented even in other parts of the world?
Definitely. We're not the first who did KMC. It was started in Colombia in 1970s, but it was not till the mid-1990s that it got recognized in the literature, and so the medical and international community started doing a lot of studies, and so many countries now are implementing kangaroo care. In the Asian region, there are 3 of us. That's Indonesia, Vietnam, and the Philippines. But, many programs in Europe and the United States are implementing kangaroo mother care.
Okay. Now, let me ask Dr. Andres, considering the method used in KMC, how does it contribute to mother-infant interaction?
Okay. Well, I guess you can call me a KMC mom because I did kangaroo care on my son. He was born prematurely, around 7 months, and he was very low birth weight at 1,100 grams. And he was born by emergency CS, so you can do it in cesarean section also. I was discharged earlier, of course, because he had to stay at the neonatal intensive care unit. He stayed inside the incubator for a month. And the most stressful thing at this time was the separation from my son. And doing kangaroo care somewhat relieved this stress because I was able to be with my son, not just in a room, because there was still an incubator which was separating us, but whenever I would get my son, he would stay on my chest. It felt right. The stress was relieved. And it helped him indirectly also because if I wasn't stressed, I could focus on him. I could enjoy. And just like what Ma'am said, during the time that we were doing kangaroo care, my son had no episodes of bradycardia or low respiratory rate. His oxygen levels were fine, and he was always thermoregulated. And he seemed content. He liked doing it. And I think it also helped for our breastfeeding journey. Maybe that's the reason why until now he's already 10 months old and we're still doing breastfeeding. Although he wasn't able to latch at once because he was still so small and very young, but the position, I think it helped. It also helped stimulate for breastfeeding. And you're more in tune with each other. I think we're very close, so the bonding is there. So that's the reason why, even though it's uncomfortable at first, because for CS, probably mothers, it hurts a bit. I love doing it, and I did it from 9 a.m. until midnight when I left the
the whole day?
Well,
9
intermittent
to
because
10?
I had to break for pumping for breast milk and then for eating lunch and dinner, but that's it. And then when I come back, I'd get my baby again. Every time Dr. Mendoza made rounds, I was there doing kangaroo care.
But I know how painful it is to have a cesarean operation. Since I had 5 kids, 2 were cesarean and 3 were normal. Compared to just normal birth, cesarean is really painful. So wasn't it kind of difficult for you at the start? Because, you can feel the wound, and then your uterus is still contracting, and then you have to be very careful with your baby, and you have to breastfeed.
Yes, that's right. It was difficult, but it was manageable. And in our case, my baby had his own IV lines inserted, and I also had my IV lines. But it was no problem because you just had to fix the positioning, and it was okay. Even with the IV lines, it seemed like she was comfortable in that position.
Okay, it's good to hear. Now, I'd like to ask Ms. Pepino, in your work as a community health worker, have you seen the impact of KMC in terms of reducing child morbidity and mortality?
Yes, I think there is really a great impact in the reduction of morbidity and mortality of our low-birth weight babies. Now, in the application of the standard protocol of kangaroo mother care, by providing the warmth of the mother to the baby, and of course the proper nutrition, giving exclusive breastfeeding, and the bonding of the baby with the mother, and of course the love and protection that she gave to the mother. This really give a big benefits for the babies. So we observe that we are no longer, or there are less referrals already to the hospitals, because in the lie-in clinic, the mother is taking care of these babies. Now with the assistance of the midwives, of course, the nurses, the barangay health workers, in the community setup. So there is less referrals, and we know that because we have to follow up all these babies in the community, so there is no more report of death. I think there's a very minimum or less percentage of it. No? So our experiences here is that we really have to assist these mothers. No? We have to empower the mothers on how to do it. No? Kasi they should be more responsible. No? If they know the benefits of this care, so I think we should be more responsible to do.